Hello and welcome back to the Medical School Companion's Clinical Pathophysiology discussion. This is Bentley Doonan with Medical School Companion. Now again, we'll be using the Clinical Pathophysiology textbook by Dr. Philip Tisdall, available through the Medical School Companion. And in this section, we're going to focus on Chapter 75, where we discuss the gallbladder and the biliary tree, which is a common site of disease. Now the gallbladder concentrates and stores the bile that's produced in the liver. It's poorly understood how the bile accumulates within the gallbladder itself, but this process is usually described as sipping. The gallbladder stores most of the body's bile in the morning and then expels it with the first food, which stimulates the release of cholecystokinin, or CCK, from the enteroendocrine cells, aka eye cells, of the duodenum. CCK also relaxes the sphincter of Oddi and increases bile acid secretion by the liver. You can see here the anatomy of the bile tree, where we have an intrahepatic segment, a hepatic duct, our cystic duct, and then our common hepatic duct. This then flows through our common bile duct and emptying out into the ampulla of Vater through the sphincter of Oddi. Some key vocabulary to understand is that chole refers to bile, or also known as gall. Cholecyst refers to the gallbladder itself, and choledochal refers to the common bile duct. Now, the biliary tract starts with a tube that's formed from hepatocytes through bile canaliculi, with the first lining epithelial cells at the canals of Herring. These flow into the bile ductules, which eventually form the left and right hepatic ducts. These fuse at the porta hepatis to form the common hepatic duct. The common bile duct is then formed after fusion with the cystic duct of the gallbladder. The ampulla of Vater is the narrowest point of the extrahepatic ducts and is a common place to find bile duct gallstones. The fusion of the left and right hepatic ducts is the most common place to find cholangiocarcinomas about half the time, and cancers at the site are often called Klatskin's tumors. Diseases of the biliary tree are typically classified as either intrahepatic or extrahepatic. Now, there's a high degree of variability in the gallbladder anatomy due to variations in embryologic development. You can see here the fundus, the body, the neck, where it joins the cystic duct. You can see this triangle of Callot is important, as this is the combination of the cystic duct, the common hepatic duct, and then the liver edge. You can then see the common hepatic duct, which is formed by the merging of the left and right hepatic ducts, and then the common bile duct, which takes place after the cystic duct. Now, the fundus is the region beyond the liver's edge, and it's the site of the maximal contraction of the organ. This site is where we elicit the pain of Murphy's sign. The body is the segment that has the maximum amount of elasticity. The neck is where tapering and infundibulum is found. And this is a Hartmann's pouch, if present, is useful for grasping during surgery. You can see this outpouching here. This is also the site of obstruction of much larger stones. The cystic duct itself is made of tubular connection to the common bile duct and has spiral valves of Heister, which are sites of small stone obstruction that can occur. The callose triangle, which has borders of the cystic duct, the common hepatic duct, and the liver's edge, is the site of the cystic artery, the left hepatic artery, and the lymph nodes. So this is very important surgically. The liver's edge is a non-peritoneal surface of the gallbladder, and the gallbladder can be completely buried in the liver or in the mesentery. Now, the gallbladder is made up histologically of multiple cell levels, and remember, it lacks a muscularis mucosa, and this is what leads to the mucosal invaginations that are seen in chronic cholecystitis, which are called Rokitansky-Yashov sinuses. But you can see here, without this muscularis mucosa, we're comprised of a mucosa, a submucosa, our tunica muscularis, and then finally our serosa. Now, acute cholecystitis is an important condition to understand, and really we need to understand the formation of gallstones. So all stones require the same conditions to form: supersaturation, a nidus, a decrease in fluid flow, and lamellation. So most stones in the United States are cholesterol stones. The cholesterol is held in suspension by micelles that are made of bile salts and phospholipids. Saturation can be due to either an increase in cholesterol through things like estrogen, familial conditions, ethnic conditions, obesity, or through a decrease in bile salts that can be seen in Crohn's disease. Now, a nidus is where a crystal requires a structure upon which to form. And in the gallbladder, this is typically sludge, which is made of mucus and debris. Decreased flow is the next step, where hydration is a key way to prevent stones from forming. Decreased bile flow can be seen with dehydration and pregnancy due to the smooth muscle relaxation effects of progesterone. And finally, with lamellation, stones require repeated episodes of layering, i.e. forming a lamella, in order to become big enough to obstruct the cystic duct, which has a normal diameter of about 1 to 5 millimeters. Now, gallstones are very common in adults, and the stones must be obstructing the cystic duct to explain a patient's symptoms. So 16% of adult females and 8% of adult males will have gallstones, and most of these are asymptomatic. Only about 20% of people with gallstones will have symptoms over the course of 10 to 15 years. Now, there are many types of gallstones, but cholesterol stones are by far the most common in the United States, and these represent more than 90% of gallstones, and, as their name depicts, they are comprised of cholesterol, which has a yellow color. They arise from conditions that cause cholesterol supersaturation, and the addition of bilirubinate gives them a green or black discoloration. Black pigmented stones are formed by bilirubinate and can be seen with conditions that cause hemolysis. And finally, brown pigment stones can be seen with chronic bacterial or parasitic infections. Now, when obstruction of the cystic duct occurs, we feel pain from distension. So the GI tract has sensory innervation only for inflammation and rapid distension. The sensory nerves called C fibers are unmyelinated and travel to the central nervous system through the vagus nerve. They are non-localizing, and the brain makes an estimate on its likely origin. This is referred pain. This is also called visceral pain by surgeons, and for the gallbladder, it's a place that's typically found in the epigastrium. Now, colicky pain is seen when there's an obstruction of the hollow organ, and this can be seen in acute cholecystitis, in a stone that occurs in the ureter, or in the conditions with the small bowel obstruction. Now, the pain that's caused by inflammation occurs later in the course of the disease. So as the obstruction continues, there becomes a breakdown of the mucosa and invasion of the gallbladder wall by bacteria. This causes an acute inflammatory response with edematous thickening of the gallbladder wall. When the entire wall becomes inflamed, the overlying peritoneum is involved, and peritoneum is innervated by lumbar nerves. Now, these are myelinated alpha-delta fibers which are localizing, and this is what we call somatic pain by surgeons. The patient's pain moves to the right upper quadrant and then becomes steady. When the peritoneum of the gallbladder fundus travels over palpating fingertips during inspiration, the pain can increase, and this is called Murphy's sign. When Murphy's sign is induced using an ultrasound probe to also evaluate for potential impaction of a gallstone, this is called sonographic Murphy's sign. Now, it's important to remember acute cholecystitis in the 4 F's. The most common patient to have acute cholecystitis is a fat female who's fertile and 40. Now, this is pretty cheeky mnemonic, but in fact it's often true. Fat increases aromatase, and females in fertility are all states with increased estrogen, which increases cholesterol synthesis. Pregnancy also has increased progesterone, which relaxes smooth muscle, leading to a decreased rate of bile flow. An older age is needed to then provide the time for lamellation and formation of a stone large enough in order to obstruct the cystic duct. Patients often present in 2 phases. An early phase, which is colicky epigastric pain, and then a late phase where over several hours the pain becomes steady and eventually moves to the right upper quadrant. Now, there are no findings during the epigastric phase. A positive Murphy sign, however, can be induced when the pain is present in the right upper quadrant. The diagnosis is through obstruction of the gallbladder neck, typically by a gallstone with thickening of the gallbladder wall through edema. This thickening can be seen by an increase in diameter of more than 3 millimeters. Now, the edema in the pericystic space and further dilation of the gallbladder can be all appreciated through ultrasound, which is the gold standard technique for evaluation. The treatment of cholecystitis varies by country, but in the United States, it's typically treated by cholecystectomy. This is a curative treatment that precludes later perforation and cancers. However, in Europe, patients may be managed with pain control over several days, after which there's usually symptom remission. Now, complications can include perforation of the gallbladder, which is a life-threatening condition, gangrenous cholecystitis, which then involves full thickness necrosis of the gallbladder wall, which leads to perforation and bioperitonitis. Often gas formation can be appreciated within the wall of the gallbladder, and this is too a life-threatening condition. Finally, carcinomas of the gallbladder is a small risk over the course of many decades, but when this develops, it's a very aggressive malignancy with a poor prognosis. Now, chronic cholecystitis can also occur, and so a clinical pathologic entity that's characterized by recurrent abdominal pain from bouts of acute cholecystitis due to gallstones. And this can be identified by imaging, which shows a contracted gallbladder with a thickened wall from fibrosis or by gallbladder dysfunction. This can be identified by a height and nuclear scan. With CCK injected, a normal gallbladder ejection fraction should be greater than 35%, so delays in this ejection can often result in chronic cholecystitis. This then further leads to chronic inflammation of the gallbladder wall thickening and eventual fibrosis. The Rokitansky-Astroff sinuses, which are areas where there's raised pressure in the gallbladder through contraction against the cystic duct obstruction, leads to these mucosal pouch formations within the submucosa. Remember, this is due to the unique histology of the gallbladder itself. Patients will often present with dyspepsia, which is a nonspecific term used to describe disagreeable sensations that occur when eating, like pain, gas, or nausea. They'll also have recurrent epigastric pain from episodes of acute cholecystitis. The physical exam is usually non-contributory, though a positive Murphy sign may be found with acute cholecystitis. Again, the diagnosis is made through imaging, where we can appreciate gallstones, a shrunken gallbladder, thickened wall, which usually is enhanced due to inflammation and fibrosis. We can also see calcifications, and these can be seen in an abdominal X-ray. Now, a HIDA scan with the tracer and injection of CCK can often be used to develop and to prove whether somebody has a poor outflow or a low output state. So the tracer is excreted by the liver at a fast enough rate that it is outlining the biliary tree on imaging. If the gallbladder is not visualized, then it is occluded, meaning it's blocked by a stone. If the gallbladder is seen, the CCK can be injected, and then the contractions of the wall of the gallbladder can be quantitated. And this can develop an ejection fraction, and if the ejection fraction is low, it's a sign of a dysfunctional gallbladder. Now, the prognosis for these patients is that they often have a 30% risk of further complications. These include ascending cholangitis, gallstone pancreatitis, and cancer. The cancer risk, though, is small. And again, the treatment of choice for this is cholecystectomy, which is curative. Next, let's discuss some malignant processes that occur within the gallbladder. We'll start with cholangiocarcinoma. So the traditional classification designated intrahepatic cholangiocarcinomas as primary liver cancers. Extrahepatic cholangiocarcinomas were then classified as either gallbladder, extrahepatic duct, and ampulla of Vater cancers. But the current classification is now the majority of these cells, the majority of cancers that occur here are perihilar. The next most common are distal or still extrahepatic, and then very few of them are intrahepatic. But this does not include the gallbladder or the ampulla of Vater cancers. Now, the risk factors for this include the condition primary sclerosing cholangitis, which accounts for up to 30% of cholangiocarcinomas. There's also association here with smoking and drinking. There are hereditary conditions that increase your risk for cholangiocarcinoma, including Lynch syndrome, a BRCA mutation, cystic fibrosis, and the presence of liver flukes. Now, adenocarcinomas are arising from dysplasia of the bile duct epithelium, but there is no clear molecular pathogenesis to this disease. The symptoms of this condition include biliary obstruction, which can lead to jaundice, pale stools, and brown foamy urine. Patients will often have right upper quadrant pain and resultant weight loss. On physical exam, they may have symptoms of biliary obstruction, which can be appreciated by inducing and seeing Courvoisier's gallbladder or inducing and noticing jaundice. They also potentially have a mass in the right upper quadrant that's more likely seen on imaging and less likely palpable. Testing includes seeing a cholestatic pattern with increased alkaline phosphatase and GGT ratios, indicating a primary liver process. Imaging will show a mass and duct obstruction, and then this is confirmed by biopsy. Now, these typically present late with advanced local disease, and survival is measured in months. Complication is that most of the worst symptoms are caused by the biliary obstruction itself, and treatment is often palliative with stenting of the biliary duct obstruction in order to relieve symptoms. Gallbladder carcinomas, on the other hand, the most common risk factor for this is cholelithiasis. So like other GI adenocarcinomas, this does follow a typical progression of dysplasia to carcinoma over many years to decades. And again, they're not well-established molecular pathways, but better so than with cholangiocarcinoma. We see KRAS mutations are very common in the dysplasia neoplasia malignancies, compared to beta-catenin mutations of the adenocarcinoma sequences. So these typically follow more of a GI adenocarcinoma histological pattern than the cholangiocarcinomas do. So symptoms, again, most commonly are incidental findings at the time of symptomatic gallbladder disease, and if symptomatic due to the cancer, the pain is the commonest symptom. Again, the physical exam is usually non-contributory, but sometimes a palpable mass is possible. Imaging and biopsy confirm the diagnosis. The prognosis in this case depends heavily on stage. Greater than 90% of symptomatic patients present with advanced disease, and for these patients, 5-year survival is low. Complications like biliary obstruction can occur, and a treatment, again, is surgical resection. And local disease can actually have pretty decent prognosis when caught early. It's just most of these patients are not found at an early stage in their disease process. Ampullary carcinomas are different again, as this is a distal process compared to the previous two we've discussed. Now, the ampulla of Vater is formed by the duodenal aspect of the sphincter of Oddi muscle, which surrounds the confluence of the distal common bile duct and the main pancreatic duct. Ampullary carcinomas are defined as those that arise within the ampullary complex, distal to the bifurcation of the distal common bile duct and the pancreatic duct. The behavior is that of interstitial epithelium, not pancreatico-biliary epithelium. This means that carcinomas typically progress through the adenocarcinoma sequence and not the dysplasia carcinoma sequence. The molecular pathways are similar to those of other intestinal neoplasia, with mismatch repair deficiencies the most common defect. Ampullary carcinomas are increased in the hereditary neoplasia of the intestine, so Lynch syndrome and familial adenomatous polyposis syndromes both can have ampullary carcinomas associated with them. Now again, most of these patients are going to present with obstructive jaundice, and again, the physical exam is non-contributory. Testing will show a cholecystatic pattern, and imaging will show the dilated common bile duct, but not usually the tumor, as it's often too small. An ERCP, or endoscopic retrograde cholangiopancreatogram, is the best procedure as it allows for the visualization of the mass, a biopsy, and subsequent injection of the biliary tree. Again, the prognosis depends on the stage, and there's a 75% 5-year survival with the complete resection and negative lymph nodes. However, if lymph node is positive, this decreases to 50%. Complications again include biliary obstruction, and currently surgery is the only curative approach. This concludes our discussion on the gallbladder and its pathology. This has been Bentley Duden with the Medical School Companion. We'll see you next time.